demonstration of perfect refractive solution part 2, and our first speaker is Dr. Ananth from Coimbatore. He will be talking regarding why TriPhobic IOL line.
So, good afternoon, everyone. Good afternoon, everyone. At the outset, I would like to thank Care Group and Ratish for this opportunity. Why Triphobic, the true trifocal? So, no financial disclosures. Our center, we are known for high volume phaco-refractive surgeries and glass-free centers, we are called. So, we were doing a lot of multifocals. So, as soon as trifocals were launched, so trifocal has become part of our practice. Whenever a non-cataractous or ametropic patients or with mild ametropia, he enjoys a very good range of vision because of his natural crystalline lenses. When the same patient comes back to us with a cataract or for refractive lens exchange to become glass independent, I always feel surgeons' IOL should be a personalized approach. It's not a one size fit which suits all the people, so we need to understand the need of the patients and we should be aware of the physics of each and every IOL. There are so many options available. So laser based corrections do not give a promising result, so earlier multifocal is almost outdated these days. It's between the trifocal and the EDOF lenses. Multifocals ruled the industry for 10 years, but lack of intermediate vision is one of the main failures, and this was a phenomenon we couldn't overcome with the multifocals. The trifocals haptives have improved better. It has improved in such a way that there is very little drop off between the points in trifocal IOLs. ADOF have developed along with the trifocals, but I could see that with that of near vision is compromised even after bilateral implantations. And since we're increasing the range of focus in ADOF lenses, there could be dysphotopsias, especially in the dim light conditions. The ideal patients for trifocal is it should be desirous to become glass independent. No other comorbidities, even moderate to severe dry eye, should not be there. Preferably, ametropic or hyperopic cataract patients or very minimal myopic patients are ideal for these patients. Lens pathologies, subluxations, pseudoexfoliation, I prefer not to do. Along with these indications, if patient is above 80 years, I don't want to take away pseudochoronative effect. If is having pre-existing against the rule astigmatism, I don't prefer to put trifocals. So triphobic, the true IOL, is also my preferred choice. You see here, it has all the good properties of what a trifocal should have. It's a hydrophobic lens. It is negative aspheric, and see the refractive index, it's 1.53. It is a apodized lens. It is a combination of plus 3.5 near, one for far and intermediate, plus 1.8. Let us understand one by one. Aspericity is very, very important because aspericity means we know that the power remains constant even at the center as well as the periphery, and it gives the same focus for both central and the peripheral. This has got on minus 0.15 as I mentioned. Whenever the lens has got a aspheric surface, it always gives the pseudo accommodative effect. It improves the contrast, and it is ideal for the young cataractus patients. Apodization was the same concept when multifocals came in, where the step heights are reduced from center to the periphery. Here in trifocal, what they have done is there is a near addition of plus 3.5, which helps for distance and the near. It's completely diffractive lens, there is no refractive component, and for intermediate, there is plus 1.8. These two are combined in such a way the apodization, the height reduces, but the angulation increases from center to the periphery. The dynamic energy transfer, what the technology incorporated into this, will help the lens, even though it is asymmetric, to have an appropriate distribution for the far, intermediate, and the near. That's why this is called as true. And it has got a square edge design which helps to prevent the PCF formation. And because of the dynamic energy transfer, this thing scattering of light is very, very minimal with this triphobic lenses. This is very important. The total amount of light loss is literally less than 10%. And this is the asymmetry was mentioning. For distance around 50, intermediate and near it's around 20%. Defocus curve, we know it's a measure to see the IOL performances. We could see that triphobic lenses, they perform very well at good range of vision. And whenever the Abbe number is more, the chromatic aberrations is reduced. Whenever refractive index is around 1.5 to 1.3, the chromatic aberrations are well controlled. So contrast is better with these lenses. In my experience, I think routinely we practice triphobic IOLs because implantation of lenses may be easy, but handling the complicated patient is very, very difficult. Since these lenses are excellent, so this has become a routine part of our practice. So in our follow-up, I could see that the majority of the patients do well better than 6.9 with bilateral implantation. They do until 6.6. The most important thing is about their intermediate vision. They are very comfortable reading their tabs or mobiles between 70 to 80 centimeters. The reading speed almost 150 to 180 words they could read per minute. Since we target ametropia, all the patients maintained within plus or minus 0.5. This is most important. There were no such annoying patients that they were so much disturbed with the disorder phenomenon of the trifocal levels that I never means what we could see in the days of multifocal. I don't want this trifocal lens inside. So annoying symptoms were negligible in this set of patients. So I could achieve what I wanted in my patients, except for 5 to 10% of the people they wanted to use at least plus one for very minute objects. So along with good IOL, other mandatory criteria is you should target ametropia, preferably use Barrett Universal 2, have a good rexis of 5 to 5.5. Surgical maneuvers should be very, very minimal. Good cortical cleanup, place always IOL in the back, do a thorough visco wash. So trifocal implantation can be performed by the surgeon who is aware of the principles of refractive surgery, and triphobic gives the excellent result for distance independent ear with very minimal dysphotopsic phenomenon. Thank you.
And one thing, very nice talk you have given. One thing I want to add that in refractive lens exchange patient, most of patient are younger and the high myopic category. The range of power available with the range is more than the what the other company provides.
Yes, sir, right,
Yeah,
right.
in the Alcon use plus 6 to 30. In either side, they are going much beyond to giving the full vision. So the problem occurs with those lenses if we need a plus 3 kind of power in the patient, then it's become difficult to choose this trifocal lens. And other thing regarding the near vision problem you talked about, is common with every lens
Yes.
in few patient, and it is really comparable to other lenses.
No,
So
no,
not
yeah.
some people coming, this patient has a near vision problem. You can even see panoptics you are putting, there are near vision problem in few patients. So it is, the result is comparable. So what other advantages you feel in
With
implantation?
the triphobic compared to other trifocals.
Yes.
To be frank enough, I think I use more of trifocals in my practice. Cost is one factor, and being an Indian company, it is as you told, the range of this thing is easily accessible. If you look into our results, see, we are sitting in a very prime center in a big city where patients do not expect that they again become independent. So we choose the patients properly. I have mentioned that only 6% of the patient, with bilateral implantations, N8 and better is almost there with these patients. Sometimes too much letters they read. I remember one or two patients telling that I read the little horoscope on the paper. Only those sort of time. That too, I've given them plus one, not more than that for occasional use. Otherwise, most of the times with bilateral implantations, they do pretty very well. More than the vision, we were bothered about the dysphotopsic phenomenon. I've made patients to drive. They come back and tell that yes, I'm very comfortable. You can proceed with the other eye. So that's most promising. Vision wise, I think N8 and better will always do good for elderly people. They'll be happy.
Anybody want to ask any question? I will 1 minute to.
This is also trifocal lens. That's it on the box. And this is also hydrophobic trifocal. What is the basic difference between both?
I think company guys should answer this. Same thing I had asked them. So
Actually, that was the lens launched 10 years back, and that was a lens at that time of maybe it was giving a bifocality along with some extent of intermediate vision. That was pupil dependent. But once the technology evolved, the trifocal actually came, and which was actually independent of pupil thing, and the entire range of vision near, far, and intermediate was possible. So this is a tradition.
It's a generation gap between
Yes.
a trifocal and a accretive platform. So
This is purely
trifobic is a upgraded version.
Upgraded.
Thank you,
Same
Doctor.
question I had when I saw the box initial days of Triphobic. Yeah.
Thank you, Dr. Ananth.
Yes.